Today, we're discussing spinal cord tumors. These are rare and complex, but they're important for nurses to understand. Knowing how to recognize the symptoms, advocate for timely imaging, and support patients before and after treatment can make a huge difference in outcomes. Let's start with the basics. Spinal cord tumors are classified by their location in relation to the spinal cord. If the tumor is growing inside the spinal cord itself, it's called intramedullary. If it's outside the spinal cord but still under the dura, it's extramedullary-intradural. And if it's outside the dura altogether, that's considered extramedullary-extradural. Primary tumors like astrocytomas or ependymomas usually grow within the spinal cord, but far more common are secondary tumors. Those are metastases from other cancers, and they typically show up outside the dura. These can press on the spinal cord or spinal roots and cause a wide range of symptoms. As a tumor grows, it may compress the nerves or spinal cord, leading to localized or shooting pain. Patients might experience muscle weakness, numbness, tingling, or a loss of reflexes below the level of the tumor. Over time, symptoms can progress to motor deficits, paralysis, and even bowel or bladder dysfunction. One of the earliest red flags is sharp pain in a specific nerve root area. That's often the first sign something is wrong. As the tumor expands, sensory loss begins to spread downward from the site of the lesion. As nurses, your neurologic assessment is absolutely essential. Pay attention to where the pain is and what kind it is. Look at strength, reflexes, any changes in sensation, gait or balance issues, and bowel or bladder control. If something feels off, trust your assessment. When it comes to diagnostics, MRI is the gold standard. It's the most sensitive tool for identifying spinal cord tumors, especially if there's epidural compression or suspected metastases. CT scans and biopsies might also be used depending on the case. Medical management depends on the type of tumor, where it's located, how severe the symptoms are, and the overall condition of the patient. Surgery is often the first-line treatment for many tumors. In other cases, especially when surgery isn't possible, radiation may be used to relieve symptoms. Chemotherapy is sometimes part of the plan, particularly for tumor types that are responsive to it, or when care becomes palliative. Now, if a patient presents with spinal cord compression due to metastatic disease, especially from primary cancers like lung, breast, or prostate, that's considered a neurologic emergency. You'll often see high-dose dexamethasone given right away to reduce inflammation and swelling, followed by radiation to relieve pressure on the cord. When surgery is needed, the goal is to remove as much of the tumor as possible without damaging the surrounding healthy tissue. Some tumors, like meningiomas that are located outside the spinal cord but within the dura, can often be fully removed. Others, especially those embedded inside the cord, are much harder to remove completely. If a patient has sudden loss of motor function, sensation, or bladder control, emergency surgery may be the only shot at preventing permanent damage. Time is critical. Prognosis varies depending on several factors: how severe the deficits were before surgery, how fast the symptoms came on, and whether the tumor is primary or metastatic. Patients with slow onset symptoms and fewer deficits usually do better. Now let's talk about your role as a nurse, starting before surgery. You'll need to keep a close eye on any neurologic changes. Assess motor strength, reflexes, sensation, and bowel or bladder function. Keep the patient comfortable by managing pain effectively, and don't forget to evaluate respiratory status, especially for cervical tumors, which can impact breathing. If the patient is on anticoagulants, that needs to be addressed ahead of time. You'll also be the one explaining breathing exercises and setting expectations around postoperative pain. After surgery, your job becomes even more important. Neuro checks should be frequent and thorough. You're watching for changes in motor strength, sensory level, or sudden neurologic deterioration, any of which could suggest ischemia or infarction. Pinch test the arms, trunk, and legs to determine numbness levels. Check vital signs, respiratory status, and bladder function closely, especially in patients with cervical tumors. If the patient begins retaining urine or becomes incontinent, that's a sign their spinal function may be decompensating and it needs immediate attention. Bladder scans and intake and output monitoring will help guide your response. Pain management is a big deal with these patients. The pain can be severe, especially if nerve roots are involved. So administer medications in full doses, stay on schedule, and aim to treat the pain before it becomes unbearable. Most patients are kept flat for a period of time post-op and turned with the log rolling technique to maintain spinal alignment. When allowed, side lying is the preferred position, with a pillow placed between the knees to prevent strain. There are also complications to monitor for. If your patient has a cervical tumor, respiratory compromise is a real concern. A cerebrospinal fluid leak might show up as clear drainage on the dressing or swelling at the surgical site. Pseudomeningocele, a bulging pocket of CSF, can also develop and may require surgical repair. Teach your patients to cough and deep breathe. Listen for abnormal breath sounds and make sure both sides of the chest are rising evenly. As discharge approaches, think about what your patient will need at home. Do they have someone to help them? Are they safe to move around without falling? Are they aware of any new sensory changes, especially a reduced ability to feel heat or cold? It's your job to educate them about skin protection, avoiding heating devices, doing daily skin checks, and using mobility aids like walkers or canes. They'll also need a plan for bowel and bladder management, pain control, and a clear understanding of what symptoms should prompt a call to the provider, like new numbness, loss of function, or worsening pain. Follow-up care may include rehab, home health visits, or social work support for things like transportation and resources. If the tumor is malignant, or the patient is nearing the end of life, this is a time to offer emotional support, help them navigate hospice if needed, and provide compassionate, honest care. In short, spinal cord tumors require nurses who are vigilant, responsive, and deeply skilled in both assessment and advocacy. These cases can be intimidating, but they're also where nursing makes a real difference. When you're the one catching subtle neurologic changes, advocating for an MRI, and teaching a family how to care for their loved one at home, you're changing the outcome.